So we're right on time, and next is Jeffrey Levi from the Trust for America's Health on broader policy. You'll have noticed just then that there was a response to Mark about something that we could do with that very important early health factor in Laura's talk. Okay.
Well, and unfortunately, my takeaway from Mark's talk is that I only have a few years left of active life expectancy despite my college education. So I want to learn more about your confidence intervals.
They're quite small.
That's even more disappointing. So I'm going to offer a slightly, that's the end of my discussion of data. So I am going to now enter a data-free zone of the policy world. But I think what I wanted, I think what I'm really trying.
Don't say that.
What I really want to be talking about is some of the opportunities that the Affordable Care Act has provided to start thinking more about population health, but also for us, given the nature of this meeting, to really be thinking about the role of policy research and policy advocacy, because I do a little bit of each, as the bridge among the disciplines that we are talking about, and as a bridge between what the science is and what ultimately happens. Because if we are going to communicate, if we have to bridge among the fields, because that's really what this is all about, but we also have to be able to translate what we are learning for policymakers. And in fact, we have to come to this very difficult space that, at least in our advocacy work at TIFA, is sometimes a challenge in working with scientists of all kinds, is that sometimes we will undertake evidence-based policy, sometimes we will undertake evidence-informed policy, and sometimes we'll take our best guess. And that we hope that's an educated guess. And there has to be space in working with everything we have learned to accommodate each of those options. Because when a window of opportunity opens for policymaking, we can't say to that policymaker, yeah, it would be a really good idea to address social determinants of health in the context of your new initiative, but it'll be 5 years till we have the full results from our study, and then we can tell you what you ought to do. We have to be able to move forward. We have to do rapid cycle evaluation. We have to be able to keep learning as we are going. But the policy world is all about doing and learning simultaneously. And what this new organization and this new interest in population health research always has to keep in mind is how the two constantly interact, which actually makes evaluation ultimately more complicated because we're constantly changing as we are going along. So I want to start with a basic premise or two, which is, as we're thinking about population health, we could spend the entire day in this room arguing about what does population health mean, and I think it means different things to different people. But I think the bottom line, for the purposes of thinking about social determinants, is really that to address any definition of population health, whether it's someone who thinks about a population as his or her patient panel, whose health outcomes he or she wants to improve, or it's a public health official who thinks about the entire world as the population, we have to be thinking of the link between what happens in the clinic and what happens outside the clinic. And as important as that link in the clinic is, and as powerful, and we know from good research, as powerful as the message may be that a clinician can communicate to a patient and therefore inspire that patient to make changes, we also know that even in the best of all possible worlds, that's a very limited, very time-limited encounter. We also know, I think the other basic premise is that the triple aim requires, so the basic premise is we need new partnerships for all sorts of different reasons. And achieving the triple aim requires new partnerships. It's between the community and the clinical, it's between public health and healthcare, and it's between the health sector and the non-health sector in addressing social determinants. But we also need to recognize that the nature of those partnerships is going to vary based on the capacity of the various players, and it could be the clinical setting, it could be the community, it could be public health. But ultimately, we have to be building those partnerships. So the Affordable Care Act, the Affordable Care Act is sort of a Rorschach test. So, some people, the Affordable Care Act is about increasing access to care. For others, it's increasing insurance coverage. For others, it's cost containment. For me, it's population health. And it's about prevention. And all of those are obviously true, but I think often neglected is thinking about the various ways that the Affordable Care Act fairly systematically went about trying to think more broadly about what contributes to health, and particularly the role of prevention, and thinking about population health, and thinking about social determinants of health. And the one sort of principal example of that, I think, is the creation of the National Prevention Council. That council is now comprised of 20 federal agencies and offices, everything from obviously HHS and VA and DOD, who run large health systems, but also the Department of the Interior and the Department of Housing and Urban Development and the Department of Education and the Department of Agriculture, all of whom have been told in statute now, you need to think about the health implications of the work that you do. Now, statute, putting it in law is one thing. Getting their hearts and minds to follow is another. And one of the efforts that the Affordable Care Act required, and there's nothing like having a statutory deadline to get people to change their behaviors, was the development by the Council of a national prevention strategy. Now, I've been begging, and maybe someone in this room will finally find a student who will do this. I want someone to do a dissertation on how the development of the National Prevention Strategy, because I think it tells us a lot, it will tell us a lot about how we change from health driving a conversation about prevention and social determinants of health to all sectors coming together and driving that conversation. The initial draft, a very credible draft of the prevention strategy, came out of the Centers for Disease Control, and it looked like a document written by the Centers for Disease Control. And so it was a lot about clinical preventive services, and it was a lot about the kinds of programs that CDC funds. And the other agencies, so one of two things could have happened. One would have been the other agency said, okay, fine, we'll sign off. There's obviously nothing for us to do. We'll clear this, and now we'll move on. We were lucky that that's not what happened. The agency said, we don't see ourselves here. This isn't what we are doing. This isn't how we can contribute. And we ended up with a much more comprehensive document that really defined much more broadly how different sectors can contribute. And I know we all use, and I do often too, the term health in all policies. But the concern I have with that term is that's what the CDC document looked like. It was the health sector saying to other people, this is how you help us. And what the National Prevention Strategy tried to do, without in any way negating the value of what the health sector and the public health sector brought, what the prevention strategy, at least as a document, we'll talk about implementation in a moment, as a document at least articulated this much broader vision and placed it in a context where these agencies could really understand it. So obviously you talked about clinical, and so if you think about the middle circle there of the four strategic directions, clinical and community preventive services, pretty straightforward. That's the CDC document. But healthy and safe community environments is not just clean air and clean water, but the Justice Department could see itself there because having safe streets meant people could be more active and people felt safer. When elimination of health disparities wasn't just what happened in a clinical setting, but did talk about income and education and housing opportunities. And empowered people didn't just talk about health, things like health literacy, but it acknowledged that people who are engaged in their communities are going to be healthy. And so every agency could begin to see themselves in that light. The reality is that the implementation of that strategy has fallen to a significant degree back into the silos of the agencies. And so within those agencies, I think the vision of the strategy is being incorporated. But I think what some of us hope for, and there is still time to make this happen, is that this would also inspire agencies working across sectors, across their bureaucratic lines in common efforts. And what we've found is when those efforts are attempted, there are huge bureaucratic and legal and procedural and financial obstacles to making that happen. A wonderful area of research for those who are in public administration. There are a few other elements of the Affordable Care Act that I want to mention quickly because they too reflect this greater investment in thinking about social determinants of health, but also some opportunities for where we've to understand where we've succeeded and where we've failed or we've only had partial success. The Prevention and Public Health Fund is the first mandatory funding stream for prevention and public health services. That's been sometimes used for new and innovative things, sometimes used to backfill existing programs. Is that good? Is that bad? You know, things could have been, protecting what we already have is not unimportant. Among the investments from the Prevention Fund have been new initiatives in community prevention. And there we still have a lot of work to do. Starting with the Recovery Act and the investment in communities putting prevention to work, CDC has really been making major, has invested hundreds of millions of dollars now in CPPW, in the community transformation grants, and now partnerships to improve community health, to bring together at the community level the various players who really can begin to address the social determinants of health through a lens of thinking about how do we reduce obesity, how do we improve access to clinical preventive services, how do we reduce smoking. But what we haven't been successful in doing is completing evaluations and doing real integration of evaluation into the ongoing work of these projects. Or we are so slow in getting our data out, we don't have the data to defend the programs when they are under attack in Congress. And so we are going to have to find new ways of both doing evaluation and getting data out and making it accessible to policymakers if we are going to protect these programs. I'll talk in a moment about some specific things around the Center for Medicare and Medicaid Innovation. But I think what's really important, and sometimes baby steps can reflect big culture changes, the fact that the state innovation model grants are now required to say how they are going to address population health. Some states are doing a really good job of trying to do that, and some states are checking a box. But the fact that it is out there and established as a goal, I think, is incredibly important. And we are learning from some of the Healthcare Innovation Awards, especially the second, that have really begun to look at both how we link people to social services, how we do a better job of addressing social determinants of health. But the challenge, particularly in the Healthcare Innovation Awards, is that they are one-offs. And we are not building into them true sustainability once we show something works. The Medicaid expansion provides huge opportunities for us to look at and to work with folks who have very high social need, but coming into a system that hasn't been adapted to address those social needs. And Laura talked about the workforce issues, and here too, the Affordable Care Act is really pressing us to think much more broadly about who is the workforce for healthcare, who is the workforce also for prevention. And there, the broader use and reimbursement for community health workers, I think, is incredibly important. And then finally, the introduction of the Internal Revenue Service as a public health agency in its oversight of the community benefit programs, of the community benefit requirements for nonprofit hospitals. And there too, this, and here it is, the Rorschach test is linked back to greater coverage. If hospitals have less uncompensated care, then those nonprofit hospitals should be able to better invest back in their communities. And, there are all sorts of things to learn from how different communities are addressing these new requirements, from very isolated hospital-by-hospital approaches to communities coming together and doing common community health needs assessments, and actually even working together on common implementation plans to make sure that we're really addressing a community's needs and a community's health. So there's one coalition, so to speak, or collaborative of nonprofit hospitals that is worth pointing out, and that's called Stakeholder Health, which is, I think, now at 40, 45 nonprofit hospitals who have come together and have recognized and made a public commitment to thinking about community benefit in a different way. And that is to be thinking about what is the social determinants of health and the health of a community as a whole. And that is the start of a new way of approaching things. These are the thought leaders, and these are, we hope, also the action leaders. But I think that also gives us hope to see that we're really beginning to see some major changes. The laboratory, we always joke about how the states and communities, the states are the laboratories of our country. And I think that's important. I mentioned this earlier, but every community is doing things differently. And I think that for us is a big challenge, because how you spread and scale success is definitely not going to be a cookie cutter approach, because so much is different in different communities. I want to mention very quickly two examples of the breadth of approaches that are out there, and say that it's exciting, but I think equally challenging in our understanding of how to transform things. So many of you may be familiar with Hennepin Health, which calls itself a social accountable care organization. It's an experiment with the Medicaid expansion population in the Minneapolis area. And what they've essentially done is created the data systems and created the linkages between social services and healthcare services, and negotiated with CMS that they can reinvest some of their savings in building new capacities. And so what you have here is a relatively integrated system, and no wrong door. You come in needing housing services and you need health care, you can immediately get linked to that health care. You come in needing health care and with a health care need and you need social services, you can get linked to those social services. It's proven to be successful. It's provided opportunities to reinvest in new ways of delivering both health care and social services. But what is unique about it is every element of that program is a county-run program. There are very few communities where that is going to be replicable, where it's a county-run clinic and a county-run hospital and a county-run housing program and a county-run employment program and so on. And so how that can be replicated in other communities, I think, is going to be a major test. The other side of the spectrum, so that started with health at its center. The other side of the spectrum, still taking what I think we would all agree is a population health approach, is Live Well San Diego, which was generated at the county level again. So we're seeing county as a leader here, but has not just health as its goal, but also living safely and thriving. And it brings together, again, social services and economic development and work in the community and braiding of multiple funding streams across sectors that the county was able to do. But again, much less focused on the core of the healthcare delivery system and really starting with what is happening in the community. Two very different approaches, both addressing population health, both having good outcomes. What they have in common is leadership and vision. They have in common an integrator or a bridge organization that can blend those efforts. They have data systems that can monitor things. They have startup funds, but we don't know yet whether these are sustainable. What we hope we can learn, though, how to replicate these models in other types of communities. And some of you may have heard that CMMI is working on a funding opportunity announcement for what they are calling accountable health communities that would provide support, CMS support, for creating that bridge or backbone organization using a collective impact model to do it and create the data systems to better link people to social determinants of health. They're not going to pay directly for those social determinants services, but they will pay for linking them. They will pay for the structure that will bring all of those services together in a more organized fashion in a community. This is a major culture change for CMS to acknowledge that direct link to social determinants of health, to believe that if we invest in addressing those social determinants of health, that we will indeed be able to lower costs and improve outcomes. So watch for that because it's very exciting. So I just want to close with a few challenges. We have some evidence that we know that social determinants matter. What we don't know as much about is what kinds of integration of social determinants with the healthcare system work. And we also don't know whether in solving a problem of the health system by improving access to social services, whether we are creating a problem on the social services side of the ledger. And I think, the CMMI experiment is a perfect example. CMS is interested in finding out whether better access to social services is going to reduce healthcare costs. A governor who is going to then be asked to embrace this approach is going to say, and what does it also do to my social services costs? And so we have to be looking at both sides of the equation, and we don't necessarily have the structures to do that. And we also need to think about what is the health system's responsibility or what is a social sector's responsibility. And where does it begin, where does it end? Should CMS have to close every single gap in social services? That would be, yes, there may be a lot of money in the healthcare system, but that may be stretching things. We have, and CMS General Counsel doesn't want to go there at all, but can you go there a little bit? And if so, how far? But I think I've also heard, in some of our work with the education field, someone from the Department of Education said to me, we have to be careful not to educationize everything. And we also have to be careful on our end not to healthize everything. If this is really about everyone achieving their common goals, and if we are doing them together in a more coordinated way, that's what we have to figure out, is how those coordinations work in a way that is truly mutually beneficial, and it isn't health coming to the other sectors and say, solve our problems. So we have a lot of research, we have a lot of policy development, we have to get away from these one-offs to systematic approaches, and we, above all, have to be able to articulate this vision for cross-sector partnership. Thank you.